In this presentation, we'll review some global health issues and concepts and discuss some of the terms that will be used in the course. Health is a global concern. With huge numbers of people, animals, and products traveling throughout the world, largely by air, disease knows no boundaries. Most infectious diseases are only a plane ride away. Air travel has increased dramatically since the 1950s. By 1980, there were over 600 million passengers traveling international. By 2000, the annual number of passengers increased to more than 1.4 billion. By 2012, the number was 2.8 billion, and the International Air Transport Association, or IATA, forecasts that by 2017, there will be 3.91 billion international air passengers. Pathogens also move with these passengers and can put entire populations at risk. Fear about the Ebola outbreak in Sierra Leone and Liberia has grown throughout the world, and now we're looking at an increased risk from the Zika virus. Infected passenger from Liberia was able to board a plane to Nigeria, where he later died. Airports are now using sophisticated temperature monitors to scan the body temperatures of passengers who are entering and leaving their countries. During the SARS, or Severe Acute Respiratory Syndrome outbreak of 2003, the global surveillance system was able to detect passengers who carried the virus from Guangdong in China to one hotel in Hong Kong, and from there to Canada, Ireland, USA, Germany, Thailand, Singapore, and Vietnam within 1 month. In order to eradicate polio, a global surveillance system has been built. Stool samples are taken from sick people who present symptoms of high fevers and of flaccid paralysis, acute flaccid paralysis. These stool samples are shipped within 48 hours to a certified laboratory for analysis. Through genotypic differentiation, each virus causing that particular case of acute flaccid paralysis can be determined to be either a wild poliovirus, a polio vaccine virus, or any of the other 72 enteroviruses that could also cause acute flaccid paralysis. In addition to determining the kind of virus, the origin of the virus can also be determined by comparing it to similar viruses throughout the world. The World Health Organization has created a global laboratory network which can track these viruses and share information. So if a polio case were found in Angola, a stool sample from that patient will be sent to the regional laboratory in South Africa. From there, it can be determined whether the virus originated in Angola or was imported from another country. If the reservoir was in Angola, the virus would be considered endemic to Angola, and a very specific immunization strategy would be implemented. However, if the case were found to be from Uttar Pradesh in India, we know that Angola is not endemic, and our immunization strategies must be focused on the exporting country and region, in this case, Uttar Pradesh in India. Understanding the global epidemiology of polio allows for more specific, targeted, and cost-effective responses. Here's what the global laboratory network looks like. This network also extends to the surveillance of new emerging diseases. The polio laboratory in Hong Kong was able to identify the SARS virus, and the same network has been used to evaluate blood samples in Africa to determine the presence of the Ebola virus. Strengthening this network is essential for the continuous monitoring of new emerging diseases and tracking the spread of disease and outbreaks or epidemics. There are other global epidemiological trends that are important to follow. The incidence of obesity and diabetes are growing steadily and are contributing to leading causes of death in many countries. Since the 1960s in the United States, there is a trend to eat more meals outside of the home. And eating outside of the home in restaurants is linked to obesity. The portion sizes of dinner plates are also increasing significantly. Which entree do you think on the children's menu at Chili's has the most calories? The answer might surprise you. It's chicken tenders. Which item do you think at Dunkin' Donuts has the fewest calories? The answer is B, jelly-filled donuts. This does not mean, however, that donuts are a healthier option. The next series of slides shows the obesity trends in the United States. These slides represent the body mass index of United States adults throughout the U.S. This data is collected through the Behavior Risk Factor Surveillance System, or BRFSS. The concern in this series of graphs is for people with a body mass index, a BMI, of over 30. This means that a person who's 5'4" would be 30 pounds overweight and will be considered obese. Obesity is a prime factor in the onset of type 2 diabetes, and you can watch the growth of the epidemic. I should say, however, that while body mass index is a very important indicator, we can't completely depend upon it to link obesity and BMI to diabetes. Some people have genetic or other physical characteristics where the BMI of over 30 might be considered normal. But for the majority of the population, a BMI of over 30 is considered as a factor for obesity. You can see the color chart on the bottom of each slide. The darker blue reflects those states with a population of 10 to 14% of the state who are considered obese. Watch the blue colors change in the following years. This slide is from 1986. Watch the number of dark blue states in 1987, 1988, 1989, 1990. By 1991, the numbers of obese people had increased so much that a new category had to be added to the table. The very dark blue states had populations in which 15 to 19% of the population had body mass index of over 30 and are at risk for diabetes. Here's 1992, 1993, 1994, 1995. Data is now being received from each of the 50 states, and the numbers of darkest blue states are still increasing. 1996. By 1997, the numbers of obese people had increased so much that a new category had to be added to the table. The yellow states had populations in which over 20% of its people had body mass index over 30 and are at risk for diabetes. 1998, 1999, 2000, 2001. By 2001, the numbers of obese people had increased again so much that another new category had to be added to the table. The orange states had populations in which over 25% of the people had body mass index over 30 and are at risk for diabetes. 2002, 2003, 2004. By 2005, again, the numbers of obese people had increased so much that another new category had to be added to the table. The red states had populations in which over 30% of the people had BMIs over 30 and are at risk for diabetes. 2006, 2007, 2008, 2009, 2010. In this slide, you can see the growth of the epidemic since 1990. But even though we see these trends, we must still understand more of the underlying determinants by specific population groups within these states. We need to know more about the contributing factors and specific distribution patterns in order to design appropriate intervention programs. In addition to being a factor in the onset of diabetes, there are other factors that are influenced by these trends. The Washington Post reported that the width of a movie seat used to be 19 inches and today is 23 inches. The average American weight gain over the last decade has required the increased consumption of 350 million gallons of jet fuel in 2000, which cost an additional $275 million and increased air pollution. There are several ways to communicate data. Here are three very innovative approaches. The first is a global health surveillance system, which tracks new cases of disease throughout the world. The second is a very innovative way to demonstrate the relationship between health and wealth throughout history. And the third is a series of maps, which presents information on the burden of disease throughout the world. When you open the link, you'll find maps of the world with data points that relate to specific health issues. This enables you to monitor emerging health issues and emerging trends. You may have seen this graph presented in a TED Talk. It's a very innovative way to present the relationship between health and wealth in countries throughout history. Please link this into your browser and you can connect to it. In the next series of slides, you'll see the way in which the World Mapper maps the distribution of specific diseases throughout the world. These are another way to show the epidemiology of these diseases, and you'll be able to note the different burdens on the United States, other developed countries in the Organization for Economic Cooperation and Development, and developing countries. You'll note that the burden of these infectious diseases is very high in developing countries, and that the burden of chronic illness is lower in developing countries because people don't live long enough to have chronic disease. In this slide, you'll note the burden of cardiovascular disease is very high in some emerging countries like India and China. This slide shows the distribution of global heart attack deaths. This slide shows the deaths from diabetes. Here's the prevalence of people living with diabetes. Here are deaths from accidents. Deaths from nutritional deficiencies. Childhood diarrheal deaths. Deaths of women from pregnancy. And these are very important conditions because they are absolutely preventable. Here is the global burden of AIDS. Here's the global burden of tuberculosis. Deaths from infectious and parasitic diseases. These are the deaths from vaccine-preventable diseases. And international organizations such as the World Health Organization and UNICEF promote universal child immunization in an effort to get every country in the world to vaccinate at least 90% of all children under 5 against the major vaccine-preventable diseases such as measles, diphtheria, neonatal tetanus, tuberculosis, polio, pertussis, and hepatitis B. And this is another example of diseases which are very preventable. Here we see the deaths from lymphatic filariasis, the deaths from Chagas disease. Throughout this course, you'll have the opportunity to research topics of interest to you or to check facts and figures. There are a number of important websites which are useful to find qualified health information about the subjects you're interested in. Please familiarize yourself with these websites and of course find others that you find most suitable. There are also many peer-reviewed articles and journals in which academic research and analysis is presented. You should review all of these sites and become familiar with the organizations and these journals. Please use the library resources that are available at Northwestern. Many of the journals are available electronically, and you can access them with your university identification. If you're not able to find what resources you're looking for in 15 minutes, please contact a research librarian who is available online to help you with your research. As a health professional, it's very important to have access to qualified evidence-based data and to keep informed about the information and research that's relevant to your personal and professional interests. You'll find that we use a number of terms throughout this course and all the other courses in the master's program in global health. We have a glossary that you'll find on Canvas, and please become familiar with these terms. Other terms can also be added to the glossary, and please feel free to share any new terms that you feel are helpful to add to the list. It's also very important that you understand the concept of epidemiology and learn some of the tools that are used to collect and analyze health data. As we've seen from the previous slides and lectures, understanding the distribution of health status and the patterns of the distribution of disease and their determinants are critical to designing appropriate health interventions. The burdens of disease that are addressed by national health institutions and other public sector, private sector, and civil society sector organizations are measured in terms of the numbers of deaths or death rate, which is defined as mortality. Knowing the incidence of disease and its prevalence in a community are essential to any public health system. The burden of disease is known as morbidity. For more information on these terms and for monitoring morbidity and mortality trends in the United States and around the world, please look at the Morbidity and Mortality Weekly Reports, which are produced by the U.S. Centers for Disease Control and Prevention and is available through our library. Two essential terms for measuring the burden of health in a population are incidence and prevalence. Incidence refers to the number of new occurrences of a condition or disease in a specific population over a period of time. The incidence rate uses the number of new cases in the numerator. It's important to understand that individuals with a history of a condition or disease are not included in these figures. The denominator for incidence rates is the population at risk. There are two kinds of prevalence, point prevalence and period prevalence. Point prevalence is the measure of a condition or disease in a specific population at a given point in time. Period prevalence is the measure of a condition or disease in a specific population over a period of time. It's a combination of point prevalence and incidence. Period prevalence is the most common measure of prevalence. Prevalence is measured by dividing the number of existing cases of a condition or disease by the population at risk during a specific period of time or at a specific point in time. In epidemiology, the prevalence of a disease in a statistical population is defined as a ratio of the number of cases of a disease present in a statistical population at a specified time and the number of individuals in the population at that specified time. In plain English, prevalence simply means the proportion, typically expressed as a percentage. Between 1960 and 2008, the prevalence of obesity in the U.S. adults increased from 13 to 34%, and the prevalence of extreme obesity increased from 0.9 to 6%. This is part of the National Health and Nutrition Examination Survey. This major shift in population fatness is called the obesity epidemic. Prevalence is useful because it's a measure of the commonality of disease. It helps physicians with the probability of certain diagnoses and is routinely used by epidemiologists, healthcare providers, government agencies, and insurance companies. Prevalence is not to be confused with incidence, which provides a measure of the occurrences of a disease in a specified time interval. Prevalence involves all affected individuals, regardless of the date of contraction. To illustrate, a disease with a long duration that was spread widely in a community in 2002 will have a high prevalence in 2003, assuming it has a long duration, but it might have a low incidence in 2003. Conversely, a disease that is easily transmitted but has a short duration may have a very low prevalence and a high incidence. Prevalence is a useful parameter when talking about long-lasting infections such as HIV, but incidence is more useful when talking about infections of short duration such as chickenpox. Health systems are designed to reduce the burdens of disease and increase the health outcomes of people. To accomplish these goals, Health intervention programs are designed to control or to reduce the incidence and/or prevalence of a disease. When an intervention program is successful and the incidence of the disease is reduced to zero in a single country, continent, or other limited geographic area, the disease can be considered to be eliminated. Due to a successful measles immunization program in the Americas, led by the Pan American Health Organization, together with the Red Cross, measles has now been eliminated from South America. Eradication is the most difficult, but is also the most cost-effective type of intervention or control program. By reducing the worldwide incidence of a disease to zero as a result of deliberate efforts, obviating the necessity for further control measures, and when the microorganism has been eliminated or completely removed from nature, only then can a disease be classified as eradicated. Only smallpox has so far been successfully eradicated in 1979. Polio is the next disease targeted for eradication, and it has been eliminated in the Americas, Europe, Southeast Asia, Western Pacific, and it still only exists in the Eastern Mediterranean regions. It's now only endemic in 2 countries, Afghanistan and Pakistan. Guinea worm has now been targeted for eradication, and there are only a few remaining infected countries left. It's important to understand the difference between control, eliminate, and eradicate. Control and elimination programs require a great deal of vigilance and advocacy. Eradication is the most difficult type of intervention, and it's only possible for a few diseases, but it is the most effective type of control intervention, and its benefits accrue forever. Throughout this course, we'll be examining the ways in which national health systems are able to prevent, control, eliminate, or eradicate infectious diseases. We will also examine the ways in which these health systems have effective programs that are focused on education, prevention, diagnosis, treatment, and care. And we will evaluate how these systems are designed to build capacity and strengthen themselves to achieve these health goals and to lower the burdens of disease. We'll explore ways in which these systems are designed to strengthen individuals' immune systems through improved access to nutrition, immunizations, and other health services, as well as education. And we will explore ways in which these national health systems work together to strengthen the national and global health systems for surveillance, education, capacity to respond to disasters, emergencies, or outbreaks, how social determinants are addressed, such as water and sanitation, and we'll look at the kinds of healthcare services that are provided and how accessible they are. For those of you who are interested in civil society organizations and their role in strengthening health systems, I encourage you to look at the NGO Code of Conduct for health system strengthening. We hope that the ultimate outcome of these efforts is to strengthen the national health systems and ensure their ability to improve the health outcomes and status of their populations.